Excited to have Shreeta Waldon with us. She received her Bachelor of Arts from Clark Atlanta University and her Master's in Professional Counseling from Argosy University, Illinois. She received her licensure as clinical alcohol and drug counselor in 2016 and renewed her certification as a board-approved supervisor with the Kentucky Board of Alcohol and Drug Counselors in 2023. Shreeta is currently the executive director of Kentucky Harm Reduction Coalition and serves on two boards: National Black Harm Reduction Network and Feed Louisville. With her 17 years of experience in the social services arena, she is recognized as an expert in the field of substance use disorder treatment and prevention. Within her role, she has been requested to present at local and national conferences, summits, and symposiums. As she is seen as a major influence of innovative approaches, her influence has allowed her to speak at the legislative hearings on topics around race and access, poverty, and policies focused on dismantling the failure of war on drugs. As a visionary leader, Shreeta has taken the grassroots agency that is built on the premises of meeting people where they are and leverages this principle in expanding beyond the Jefferson County line to touch Kentuckians throughout the state. Today, we would like to welcome Shreeta Waldon. Thank you.
All right. Thank you for that beautiful, beautiful introduction. Um, so I'm really excited about getting started in this conversation. I got to be honest with you guys. I like dialogue, so I know that this is going to be really awkward for me to be just talking to you and sharing. But we're going to make it work. So welcome, welcome. Thank you so much for that beautiful introduction, and thank you to the Kentucky School for allowing me to share space today with everyone. So we're going to just get started and jump right in. I'm going to share my screen. One second, you guys. Here. And if at any point you have any questions, you're going to ask the questions in the box like you were instructed. Um, I would like to say though, please do not get concerned if you are asking a question and I can't see it. The host and the moderators will attempt to support me and get those questions to me so that we can meet your needs. So today's presentation is on radical inclusion, leading from the lens of harm reduction. So quite a few of you may be very well aware about harm reduction. You may have heard what harm reduction is. You may have experienced being a part of harm reduction services yourself. And some people may just know about a few things, which normally what I hear in response to when people say harm reduction is syringe service programs. So being in this space with you all, and we're talking about substance use disorder, clinicians, peer support, targeted case managers, people who work in the field of substance use disorder, is really understanding how harm reduction can be a part of your practice. And that's something that a lot of people are not aware of. And that's what we're going to talk about today. You all have heard my bio. This is who I am. I'm also a mom, a daughter. I'm a mom of two of my own and of a bonus child. I am a friend. I'm a sister, cousin. I'm so many things, right? So I like to call myself a guide. Throughout this time together that we'll be sharing space, I don't want you to just see me as a facilitator of a webinar, but as a guide through the process and really trying to understand what it is we're talking about. Because if you started like I did 17 years ago in this field, you may have had times where you were ambivalent about the thoughts of a different way of practicing. So I'm a guide. I'm a guide. Introduction and objectives. So this is a 2-hour session. We will take 2 breaks. The first break will be after 50 minutes, and the last break would be for 10 minutes. The second break will be around the hour and 30-minute mark and last for about 5 minutes. So just want you all to be aware that we will take time to stretch. We get it. I do not want people to zone out. I really feel like this information will be helpful. So in my hope for you to take away what you need, we will take some time to step away so that we can refresh and come back. The learning objectives, we're going to identify the 3 core principles of harm reduction, how we can apply the harm reduction principles in utilizing a client scenario. And then lastly, integration of these 3 actionable harm reduction strategies into practice. That's where we're at. Learning objectives should not be overwhelming. So at the end, you should be able to walk away with some knowledge that you may not have been aware of before. All right, here we go, you guys. The first thing I want to talk about is what is harm reduction and why it matters in the field of substance use disorder. What is harm reduction and why it matters? Can anyone, and now I need some moderators to help me with this because I do have some engaging parts of this. Anyone want to throw something in the chat and share what is harm reduction and why they think it matters in the field of substance use? And if someone can share with me what's being said.
One person says it's meeting patients where they are.
Yeah. Okay, I can see some things: preventing further damage. This is all accurate. Yes. Reducing harm for those who are using substances. Oh, you all are coming in fast. Good. Thank you. This is cool. Wow. And I'm seeing the answers. And yes, I appreciate you guys sharing. And all of these things are absolutely true. I want to show you something, though. We're going to have a little fun with this. This garden right here, the gardens of life. What do you notice about these 2 gardens? What do you notice about the 2 gardens? And moderators, you can help me.
One has a path,
Different
context. One is neat and organized.
Right. So and we could just keep, like I said, this is the way that I built this out is really a dialogue heavy. So we're going to be really working our moderators today and our hosts. Yeah. So when you look at one, you see it looks so neat. It's like they really took time in the details of making sure that the curves were accurate, that everything's lined up. And then the other one is just kind of like this beautiful, glorious kind of wildflower, but it's also a garden. It's different types of flowers that kind of bushling all over the place. What I see when I look at these two gardens is what the field of substance use disorder and recovery and treatment could look like. You know, I think there was a time where that top photo with the curated garden, the paths clearly lined, was an action in a way that we address substance use disorder in the clinical field. I feel like that was the plan. We start here, we help people work through the stages of change. We help them identify what their substance use disorder is and their, you know, the consequences of their actions, learning to accept. That's what that first picture reminds me of my earlier years in treatment and recovery. The bottom picture to my right, what that picture reminds me of is maybe the treatment process doesn't look so much like this curated garden up at the top. It's got flowers poking out from each way. It's got the grass, you know, up on one side, down on the other. There is a path though. And if you recognize both of them have a path, they just look different. Mm-hmm. And what I tell people is that harm reduction isn't either or, it's both and. Both of these gardens are relevant in the treatment process. Both of these gardens matter in the recovery process. Both of them can be utilized in this process. It's both and, it's not either or. So when we start to talk about harm reduction, it's not looking at it from a lens of this is another way, it's how do I integrate it? But before I can do that, I have to give you some background and some context to understanding harm reduction. Like I said, some people hear harm reduction and they're like, oh, it's syringe service programs. It's the needle exchange. It's giving safe smoking kits, right? It's drug testing. Yes, it is. It's that and, right? At its core, harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on the belief in and respect for the rights of people who use drugs. And that's an actual definition that you can find on the National Harm Reduction Coalition's website. It is rooted in the respect for the rights of people and despite their relationship to substances. It recognizes that abstinence is not the only path to improve health and well-being. As people said in the comments section, harm reduction is about meeting people where they are without judgment. It acknowledges that people engage in behaviors that carry risk. Instead of focusing on an all or nothing approach, we work with people to make safer choices. Harm reduction, look at it up here on the screen. There's multiple movements and strategies emerging across the United States, you guys, from the 1960s all the way up to currently. If we look at where the Black Panther Party started their programs, like the breakfast program for children and the health clinics in the community, harm reduction, meeting people where they're at, bringing services to people. The Young Lords and their launching of the acupuncture program for heroin users in the South Bronx. The Black Panthers also did it in California. The women's health movement emerging from the feminists of the 1970s to focus on reproductive health, which we're still fighting today. And then we can't forget about ACT UP and the AIDS epidemic and what happened in the 80s and how people came together to fight for change, social justice, health justice. So harm reduction is bigger than just what some of us have been told, even including myself as a clinician. Doesn't it sound like it's actually a part of the clinical spaces when we talk about substance use disorder? Wow, I'm supposed to enter the field of substance use disorder and be non-judgmental. I'm supposed to meet my clients where they're at. So my question goes back to, well, why aren't we doing it? What is different? If we're looking to save lives and improve engagement and care and foster trust between providers and clients, why haven't we been bringing and bridging the gap with harm reduction modalities? Yes, the entire premise of harm reduction is nothing about us without us. Isn't that the same idea of the peer support program? These are people with lived experience helping guide another into their recovery pathway. You know, and when we sit with that and we reflect and we take a look at what we're doing today, right now, in this session with me, can I honestly say, as a practitioner, as a peer support, as a case manager, as a social worker, am I utilizing these principles of meeting people where they're at, truly doing that? And if not, am I ready to start today by making some simple changes in my thinking? If your answer is yes, then I'm going to tell you it's going to get a little uncomfortable. Okay? It's going to get a little uncomfortable. The thing is, you guys, I had my teachers and the people who taught me, helped me grow in the field of substance use disorder, addictions treatment. I believe a couple of them have passed already. They probably would be turning over in their grave right now if they knew my work. If they knew that I walked into the current position I'm in right now in my first day at work with my team back in 2022 in January, when I walked in and saw my team sitting there putting together safe use kits, and I saw cookers and I saw wraps and I saw tourniquets and I saw syringes, and I was like, I had to step back and I said, whoa, I actually had people discharged from treatment programs for bringing in for bringing in these items, and my brain is just like skipping out, but I bet you all are screaming it at your computer for me right now. But what are they called, y'all? Come on, help me out. Help a sister out. You know what I'm about to call them? Because I'm sitting here like, this is why I like to have conversation. Who got the answer for me in there? What do I call them? Has anyone answered it?
Paraphernalia.
There we go. Thank you. Good God. I have no idea what happened to my brain. I had a real brain fart there. But hey, it's real. And you all know, those who have been in a class with me know, I'm gonna keep it all the way 100 while I'm doing these classes. So yeah, paraphernalia. I couldn't believe it. It was a shock to my system. So I had to step back and I had to sit with it. And I also had to determine, what was I struggling with? What was I struggling with? Was I struggling with not understanding the harm, the risk to harm? Or was I struggling with my ethics and my board of ethics that say you're not supposed to be directly providing services in a clinical space to someone who is actively using? And I had to sit with that. I said, oh my gosh, well, I'm not doing clinical services. So what am I really struggling with? Oh, my internal biases. This slide says, let's get to it. How? Well, the first step is we have to acknowledge that we got some biases, you all. The thing about biases is that they're not bad. Everyone has a story about why they go into the field of social services. So that's social work, substance use disorder, clinical services as a licensed, a licensed clinician, licensed mental health clinician, licensed professional counselor, LPC, licensed clinical social worker, marriage and family therapist, case managers. We all have a story. I used to say at a treatment center I worked at years ago, in outpatient, that even the maintenance crew have a reason why they're doing maintenance here, right? Everyone has a story. You guys, that's where biases come from. Our lived experiences comes from our why sometimes. So how we get started is first acknowledging our own biases around what comes up with us when we think of harm reduction and what is the first thing we think of. And exploring that. I don't ever shut people down when they say, I don't like the idea of harm reduction. I actually lean into it because I want to know what is coming up for that person. So you start there. What's coming up for me? And you sit with it. No, you don't have a solution right away. You don't know the answer right away. What you do is you sit with it because now you're aware that there's something internally I'm battling with, which is a cool place to be because now you know it's not your client. Now you know it's not the participant. Now you know it's not the patient, it's you. So I can't fix that for you right now. I just want you to sit with the discomfort. I want you to sit with whatever that is that's coming up for you as we get ready to move through. And stay with me. Harm reduction has a set of about 8 principles. It has like a foundational principles that lay the foundation. Let me say it that way. What I did as a clinician so that I can work through my biases, but also provide the needed support I needed to in my role and to as a leader and to my team was I broke that down into 3 core principles under harm reduction. We have the foundational principles of harm reduction. There's 8, you can go research them. But there's 3 core ways to work through these principles. And the cool thing about this is the agency I work for utilizes these as pillars. And they're engage, educate, and empower. Engage, educate, and empower. When we think about how we want to approach the work that we do in the least harmful way and continue to provide the support for our clients and the populations we serve that will reduce the risk of harm to themselves and the circles of love that surround them. We have to start on a very basic level. We can't jump into showing people how to do something different before we start with engagement. The first core principle, engagement. Engagement equals respect and dignity. When I talk to one of our now new outreach workers on our team who originally started providing volunteer work before he became an outreach worker, and prior to that was receiving services at our harm reduction spaces. I wanted to really understand how he got from point A to point B. And I am definitely going to pay attention to raised hands. Please feel free to do that, you guys, because again, I can't hear and talk to you in real time. So I definitely want to be intentional when someone has a question or want to make a comment. So I have a raised hand. Okay. And what do I do next, everyone, my host?
So it looks like Michael Gosser has a raised hand. If you could put in the chat your question.
And we could take a beat for a second. And that's a good spot for me to just kind of pause because I don't want to lose my spot. Oh, it was accidental. Okay, no worries. No worries. So I wanted to understand how this individual went from point A, which is starting off with our services, moving into volunteering, and then moving into the role of outreach specialist. And what that individual shared was that, wow, I felt like I was receiving respect from the beginning. I mean, think about how dope that really is. What I heard him say is that he felt like we were being intentional by being non-judgmental, by focusing on what it was he was asking for in that moment. And it actually built a foundation of trust and this mutuality. Wow, think about that. Now, if you think about it on an end of what we do in this work as people with licensures and certifications, what do we call it in the clinical space? And no, I'm not asking you because I had a brain fart. I'm asking you because I know you're thinking about it. We call it building rapport. When that dawned on me as a clinician by trade, I was like, oh my gosh, engagement is this building rapport. Don't I naturally do that? But I had to stop. I had to stop and say, well, still I'm missing something. So going back to that same individual, well, what was different though? What was different than you going to the 10 treatment programs that you've been to before and having a good clinician and a good case manager? Well, I didn't have to come to you, Shreeta, like you all came where I was. The engagement process and the trust process, the foundation of trust process, the dignity process is that I'm not afraid to come out to you. I'm not afraid to step into your space, and I do it safely. What was he talking about? You came out to my encampment. In the original format of drug and alcohol treatment, any clinical services, even peer support, we are sitting at desks, you guys. We're sitting in residential treatment programs. We're sitting at the desk. We're waiting for people to come to the space. I love that. Rapport or alliance is better than any technique we would use in the work. Yes, Stephanie, thank you. Being able to go out instead of saying, you must come in. You got to trust me from the beginning that when you show up in my office, I'm going to be the Shreeta that I turned out to be. No, I went to them. My team went out there. Some people may be saying, but that's all good. I told you it's going to get uncomfortable because I get it. Some people may be like, yeah, right. That's all good, Shreeta, to go out there. But for real, clinicians, how about this? On my mobile unit, through Kentucky Opioid Response Effort funding, Dr. Christopher Stewart, some of you guys may know him. He's a psychiatrist of addictions medicine at U of L. He was working, I started this job in January 2022. Sat down with Dr. Stewart and we had to revamp our initiatives. Dr. Stewart's role, you guys, is to go out into the field at our syringe service programs and provide Suboxone care, initiated out in the field. And when we sat down to revamp the plan, because we weren't getting a lot of people saying they were interested, what we discovered was we're going to have to slow down because our of course, our goals with our lovely states, right? All of you that write proposals and say, hey, we're going to meet 250 people and get them initiated on medication they've never been on before. I mean, listen, the goals were lofty. Sat down, and as we talked about what he was recognizing, what he was observing, Dr. Stewart shared, you know, a lot of people are coming to see me and they're learning. They're actually coming back more than once, twice. They even come back about 10 times to talk to me at the site. Wait a minute. They feel comfortable enough to talk. Yeah, they do. I said, what if we lowered that number and went back to the state and said, we need a second opportunity to try this? I said, what if we had 2 days out of the week that you go? Let's go on a high traffic day and you talk to people, just share the information like you're doing. And then what we're going to do is have one of our outreach workers provide them with a card to a number to our people who could further that conversation. And the second part is, instead of them coming to you automatically, maybe they can go from the site to a pharmacy right then and there instead of coming to you to get the prescription. You guys, within just about 3 months of changing our approach, Dr. Stewart came back and was like, I actually rather and enjoy being out in the field. We were initially, I think we had like 10 people signed up, and this program had started a year prior to me starting. It was like 10 people who may have consistently come back. After that, we had that first 3 months, we had about 20 folks who were we were just tracking them, talking to him. We didn't just track them. The numbers that we were supposed to track were the numbers of people being initiated on treatment. But what I started showing people was the engagement process was the important part. We started tracking how often they were talking to him. And Dr. Stewart, I said, well, what do you think it is? He says, I'm teaching. I'm engaging. I'm talking to them and I'm sharing. His level of engagement was about educating them on what this really was and helping to break down some of their own barriers and their own stigma, like their shame, their guilt, their stigma around what Suboxone really is. And no, it may sound like I'm talking about the core principle of education, but I want you to follow me. What they started building was trust. The magical thing that started to happen, and I see Stephanie has her hand raised. The magical thing that started happening is by year 2 of me being a part of this program, we ended up having, I think he said 30 people initiated. Now, that 250, I always said was lofty. Because as a clinician, I knew we were going to be engaged in a population that when we look at from clinical space, these are folks that are ambivalent, pre-contemplation, they are not ready. They're still using. They don't have any skills to go along with this yet. So why would we say that? But everyone saw, including Dr. Stewart, saw the benefit of going out into the field and beginning that engagement process before they get to his office. I see the question. I mean, can anyone read the question for me for Stephanie? I'm gonna pause.
Yes, I can. Since we are talking about rapport, what are some effective ways to establish rapport with a client that is court-ordered to treatment and does not want to engage?
That's a great question. I'm such a harm reductionist by heart. I always like to start with people out in the audience. You guys like, what do you guys think, right? But I get it. This is where it gets tough. I want you to think about this because this is what we do. In that engagement process, when we find out people are expected to do something, I'm not responsible for taking away the natural consequences of their actions. I start out asking people, because I also do classes, I facilitate classes, DUI classes. A lot of people court order with me. The first thing I do is talk about self-determination and autonomy. I'm not responsible in a harm reduction way of thinking. I'm not responsible for the outcomes of an individual's decision. So when I ask someone, why are they here? And they tell me that they are to report to court their compliance, and I am to support that by their compliance to this program. They now, oh, there we go. They now have a choice. Looking in the comment section, give him power. He has the choice to participate in counseling or not. Let him know what the sessions are about and what he wants to work on. The cool thing about this is that I have removed myself from a God complex of I'm the end all be all. And that is tough. I'm gonna tell you something. When we get this license and when we get these papers, I do believe that a lot of us get in a position where we are the end all be all. And I also believe in our positive intent that we do not want to see our clients and the people we work with suffer consequences. At the same time, it's not our life. Harm reduction allows. So yes, we're talking about the engagement process. We're also going to talk about the empowering. Engaging is literally about planting the foundation of a relationship. We can't effectively support an individual if they do not feel safe with us. So I don't give a damn if, you know what, if they know they're going to get locked up tomorrow or if they don't show up. It doesn't matter if they don't trust me. If they don't feel safe with me, I can't make a person feel safe enough to believe me. You know what, a statement I learned at a conference, I never got the person's name, but I always say that I told them at that conference, I stood up, raised my hand and said, can I use what you just said? I will not remember who you are. Because I've been to like 1 million conferences, you guys. But I remember the statement. I've used it in every conference, every session, every group I have. It's that I'm not asking you to trust me. I'm asking you to try me. That's it. Try me. Ask me. I'm going to tell you truthfully. Well, you have a choice. You don't have to stay here. Like I said in DUI class every time. This is a system. This is a system. The system says you are to follow these criteria. Should you not follow these criteria because you put yourself in the system, you will have to deal with the natural consequences of that. This is not Shreeta's doing. This is not anyone's doing. But guess who has the power and control to make sure this happens? The engagement process in any level of this relationship is to meet that person. When someone comes in angry and they're like, I'm mad. Okay, so what's your goal? To finish this class, to get my license and get out. Great. Let me tell you how to do it. And if they choose not to, I release and let go. See, the thing is, people who are using, they're already facing judgment, discrimination, criminalization. They already have a deep mistrust of the healthcare system. Listen, you guys, we're in a whole pandemic that was initiated by a system. It's not a secret. I'm not being a revolutionary. Yes, I am. I'm being a revolutionary right now because I'm sharing with my peoples in this field. But I'm not being a rebel in that I'm saying, we know it. It's clear. We have a whole payout. The opioid settlement was proof that our clients didn't lie. They do not trust us. And you know what? As much as I am for all my clients and the participants I work with, they do not trust me automatically. And guess what? They do not have to. So it's the first thing in the engagement process is leaving it up to them. If they don't want to engage with you, it don't say nothing about your clinical skills. It doesn't mean you suck as a therapist. It doesn't mean you're a terrible case manager. It means that person is where they're at right now, and I have to be okay with that. Yeah, they may end up locked up. But guess who they may come back to? Stephanie, you asked that question. They'll come back to you because you are honest. You built trust with them. You created a space where they felt safe, seen, heard, valued, using person-first language, avoiding the moral and morality around it, avoiding moral judgment, prioritizing their lived experience, understanding that a person coming into your office who has battled substance use disorder, remember, when you diagnose or you know this person is coming to you, you're already thinking, gosh, they have already encountered a system that has failed them. So let me listen to them. Because guess what? They are experts on their own lives. You can write this question down. I think I have a way to do this, you guys, Greta and Diana. I want you to write this question down. Maybe someone can type it in the chat or something. What does it look like to truly meet someone where they are? And how can you build trust with a client who has been dismissed or harmed by the system before? I want you to write it down because I would like to see it later when we get to that part, because we do have question and answer part of this. And if you want to share it later, I would love for you to share it where I can read and I can comment and engage with you.
Excuse me a second. Let me get the rest of that. I got, what does it look like to truly meet someone where they are?
And how can you build trust with a client or a participant who has been dismissed or harmed by a system before? Write it down, you guys, and jot down your answer. And when we when we get to the end of this and we do questions and answers, this is one that I would love to see some of you guys comment on. We're going to continue to explore and move forward. And we'll be coming up on our first break here in about 10 minutes. But we'll be exploring more of this as we move into our second principle, core principle. Core principle 2. Educate. Educate equals practical strategies. You know, I know some people may have been hearing and listening and thinking, gosh, but engagement sounds like education. It can be tricky. I'm going to be honest. Y'all, I'm a solution-focused person. I am. I'm like, you come in here with a problem. I'm like, listen, what we going to do next, right? It's so easy for us who are fixers, healers, to be like, oh my gosh, I'm ready. I got a strategy. I got it. Look, you can go X, Y, Z. I mean, I love it. I've done risk management for years. I like live in preventative ways to fall. Like, I don't just have a plan A, B, and C. I have plan A through Z. I mean, I'm working out. So when someone come to me, I'm like, oh yeah. So the idea that I have to slow down and I pause a lot, and that I'm thinking about all of the things that I can teach in the moment as I'm building rapport or alliance, as I'm engaging, I have to slow down, because there is a part where now the education, and let me keep it real simple. You know, when that part comes up, you guys, the education, people start asking. People start asking, you know, in this space, especially, and I know my alcohol and drug counselors and therapists on here, it's so easy for us to want to offer our feedback, because it's like we see that train, we see the train crash, we see it so many steps before our people do. But that waiting for them to direct that path, to start asking. So what's an example real quick before I just jump into unpacking? When I started my role as executive director, and any role that I'm in, I like to be very intentional and I like to observe. Now, in this role with Kentucky Harm Reduction Coalition, I had to. I mean, remember what I said happened when I walked in and they had the cookers and the tourniquets and syringes. I was like, oh, all right. So I said, I got to get out here and see these syringe service sites operate. Now, don't get me wrong. I've seen syringe service operate before, but I needed to see it now as a leader. I needed to see it as, how am I going to be an effective leader as an LCADC in this field? And help people to see both ends. I have to believe this first. So I went to the syringe service sites and I did boots on the ground efforts by going out doing outreach with my people. And I can't tell you all, being at our syringe service site and watching people come back and forth, asking for their syringes, that internal battle of wanting to go, hey, I know a residential treatment program you can go to right now. I can call them up. Oh man, so many days. So many days. And in fact, I was not the one. I wasn't there when the magical moment happened. The magical moment happened when I hired on my new harm reduction manager at the time when I first started, and she became a harm reduction manager. When I started with her, she was an outreach specialist and a person with lived experience, was in recovery. She had got promoted. But when oops, hold on, I'm messing with stuff on my screen. Oops, okay. When she went to a site and we were checking in after her work because she was new and I wanted to see how things were going. And she told me about an experience that she engaged with this young lady that was coming back and forth to the site apparently for months. And this staff person of mine looked at her arm because it was exposed. It was the summer. And she said to her, you're missing spots, right? You're not hitting the right spot when she's shooting up. And the participant looked up at her with like a strange look and was like, how you know? I used to do that. That's what the staff said. And she said, well, what am I supposed to do? She said, well, this is what you're doing. She explained. Now, I can't break it down. I've never used syringes, y'all, but I'm telling you, the staff person of mine told me what she said. She said, you know what, Shreeta, it felt awkward. Like, I'm like, I'm not telling her what to do. So she left. She came back. She came back and forth for more months. You guys, she ended up getting pregnant. She was still using. But during that time, she started asking the staff more and more questions. How is it going to impact my baby? Well, am I going to get in trouble? Oh, staff told her, look, listen, I'm going to tell you, you go to the hospital, and because of who you are, a lot of times, statistically, they'll pick on you first before they pick on me. My staff person was white. This participant was Black. You guys, that woman disappeared. Now, I'm going to tell you something that's scary for my team and why we do a lot of self-care. When people disappear, it could be a couple of things. But the thing that happens with my people, because they are people with lived or living experience, is that a lot of times we think people have died. And it has happened. This particular client, you guys, I was at a event, like a health fair kind of, where all these different booths were. This client came up to my table and her belly was big. And she looked at it, and she said, "This KYHRC." I said, "Yep." She said, "Well, I was coming before." And I said, "Well, I want to say," now I did notice she had blotches on her skin. I could tell that maybe her skin from scratching, from use, you could tell she was digging in her skin. Her skin actually looked healed. So when we work in the field with our people, we acknowledge when we know things are happening. I said, "Your skin looks beautiful." She said, "Well, I just came over here to say that I'm in a treatment program, and look at my belly," and put my hand. She took my hand and she said, "Touch my baby." And she brought up that stab her. She said, "Man, she was telling me everything." She's like, "But I'm going to have a healthy baby. I'm in the program. And then I'm going to get some assistance. I'm going to get housing." Y'all, listen, when I tell you that many times I'll be wanting to cry, I just have to hold it back. I'll be like, "It happened." That education piece, no matter what, no matter that strong desire to say, "Hey, I need you to stop." Like I said, when I would show up at these sites, "I need you to do this. I need you to go in. I don't want you to die. I don't want you to have an unintentional overdose, fatal overdose." The beautiful part of someone saying to you, "I have built so much trust in that engagement process that I now trust you to give me valid information, accurate information, stigma-free information. I trust you to give me what I need to be equipped with to make a better decision, a more informed decision." One of the biggest myths about harm reduction that pisses me off is that people say we enable people to use. It is so hard for me to slow down with education, but I'm so glad that I'm sticking the time with y'all, because we're going to pause so that I don't go into empowerment. But in reality, if you follow those first two core principles, engagement, education, naturally, it empowers people with knowledge to reduce their own risk and improve their own well-being. Gosh, that is what it moves to. So we are at 49:21. And to allow me to let this kind of simmer and sizzle with you all with a little razzle dazzle. I want you all to sit with this. So we're going to exit for a 10-minute break. I'm going to read through some of these comments and just understand where people are at. If you want to just add comment, if there's questions, I may bring it back around, but please feel free to pause for 10 minutes and reflect, stretch, get up and stretch. We're at the 10-minute mark. I'm going to go off camera.
So we'll return at 2:05. 2:05. Ms. Shreeta, someone that knows me sent me a text message and said, "Could you kind of keep your voice up?" She said your voice, when your voice goes lower, it was difficult to understand. So she
Cool.
wants you to.
Can you hear me now?
Yes.
Okay, so it's when I get all passionate and stuff, probably. So
Okay.
I can't,
aware.
I'm not gonna turn my camera. Oh, I can. I'm gonna turn my camera off and mute for a second because I'm a stretch too. All right. Looks like our interpreter's back, and I wanted to be respectful and responsible. But I was looking at some of the comments and about the picture, and you guys, absolutely amazing. I love it. It sounds like we got a lot of creatives in this space, a lot of artists. The way you guys looked at the picture, but Jeremy Hale says one looks like it could use a little assistance from the trimmer, some type of trimmer. I'm not a plant person, but I laugh. I chuckled at that, and I'm like, that's so cool. But just acknowledging the comments through here, and really it's very heartening, and it feels good to see that we're all really going in the same direction. That can be difficult at times. I still want people to challenge if there is things that you're struggling with, put them in the comments, raise your hands. If I'm saying something, you're just like, no, Shreeta, you gotta at least address this one thing that comes up and why you feel it is bothersome. So like, I'm okay with that. And I'm also okay with saying, right now, your guide would go down a pretty deep rabbit hole and would totally take over this PowerPoint presentation, and you all not get what you need. So we'll have to circle back, or we can schedule time together to unpack it. So I'm being really good today, trying not to go down those deep rabbit holes because it's easy. Let's see. I love how people are talking about the engagement process and understanding what that looks like. A couple more minutes. Did I freeze, Phyllis? Are you able to see? I was probably just sitting here looking for a very long time, maybe. Okay. I think the way I was looking. All right. Okay. So we're gonna jump right back in. And we are now, like I said, as we were wrapping up before the break, we're now talking about the engagement. The empowerment. There we are. Sorry. Let me get my stuff back up here. As I said, once we really look at what we're doing in these core principles, education, engagement leads to the education, which is dialogue, which now leads us to empowerment. The question that does come up, and I'll slow down this time as we segue into empowerment. And if you want to answer this one at the end, it's perfectly fine. But the question before we really dive into empowerment is, I want you to think about a time when you had to make an important decision. How did access to that information, how did your ability to access that important information? Let me answer this one. How did access to information impact your ability to make the best choice for yourself? Let me repeat it. I want you to think about a time where you had to make a very important decision. How did accessibility to information impact your ability to make the best choice for yourself. So this is you. This is you. This is not about your client. This is about you. And if you all could write that in the chat for everyone, and that's something we will circle back to. I think Jeremy has his hand raised. Oh, okay. Good. People are just answering. You guys are on it. You know what? Side note, I see why they have us all on chat, you all, because we would never get through this in 2 hours because I love dialogue. Repeat the question. Think about a time when you had to make an important decision. How did access to information impact your ability to make the best choice or best decision for yourself? And really sit with that. That's the question to end out core principle 2, which was education. And I'll let me stay up. Let me make sure I keep my voice up. Empowerment. Someone has their question, their hand up. Empowerment equals autonomy and self-determination. Harm reduction, as we know, and I don't want to be too repetitive because it makes sense. At some point, we start to see, wow, it makes sense. It's practical, right? Harm reduction is about supporting self-determination, everyone. I tell people in this space, and I've had the ability to talk to people who have been in harm reduction spaces for many, many years. As a clinician coming out of abstinence-based treatment, abstinence-based approaches, a lot of what I learned early on was that our clients no longer knew what they really needed, so we were responsible for providing that pathway. Now, I say it like that because some people may say, no, that's not true. And I'm like, I broke it down into layman's terms and made it, I'm gonna keep it real simple with you guys. We were the experts. I'm a licensed clinical alcohol and drug counselor. You should listen to me because I know what's best. You lost the ability to listen to yourself because you have the legal, criminal legal system down your throat. So you no longer have the ability to make your own choices. And if you all sit honestly, especially in residential treatment programs, and especially in some that are ran abstinence-based, you know what I'm talking about. Talking to folks who have been angry by the residential and outpatient treatment programs, who have been working in harm reduction spaces, who have been harmed because these are people with lived experience. And in discussing the fact that this is what we thought was right, it's an unintentional harm because all of our goals is to do no harm, right? Our ethics is to do no harm. So with that being said, there was a lot of amends that I did, especially going to the National Harm Reduction Conference in Puerto Rico in my first year in this role. And hearing that big rift between treatment and recovery folks and harm reductionists, which is why my first presentation was not either or, it's both and. Because as a clinician, my role is to help guide my client through their pathway, not build the pathway for them. Help them to identify the options because I presented them, but not make them choose it. Empowerment means shifting from the fix it mentality to it's me and you. It's a collaborative approach. Some people may say, but that's what we do, Shreeta. We're supposed to collaborate. Come up with the treatment plan and goals. Let's get real. Let's get real. I want, especially you guys that work in mandated treatment programs. Come on now. How many of you guys really believe what you're doing is building the treatment plan goals centered around your client's goals? The first question that was asked, and it's not to pick on anyone, but the first question that was asked was right there. The first goal is to meet the requirements of the criminal legal system, make sure that they are compliant. How's that collaborative? You know why it's not collaborative, you guys? Because we've been taught in these spaces that if the client chooses to say, I do not want to do what this judge told me, my probation officer is a jerk, what is the first thing we say? They're being resistant. They're being resistant to treatment. This client is ambivalent about change. Think about it. We gotta laugh at ourselves sometimes. I had to. They're ambivalent. Yes. We have to start talking about, and I'm going to. Aren't we all ambivalent about change? Yeah. High five, air high five to Joe. Aren't we all? Ambivalence. When we start to really dissect ambivalence and what we are talking about, and when I really start to challenge people, any clinician that's under me that I have provided any support or guidance, when they tell me this person is ambivalent, I say, okay, your prognosis, your recommendation, is this based on them being ambivalent? Share with me why this individual is ambivalent about change. Well, because they have not been showing up to group on time, and they refuse to engage in the clinical process and talk to their therapist about, and they were written up by their peer support in the treatment program because they weren't following the rules of the program, and they're resistant. I said, I had a therapist actually, as I thought through that example, I remember saying to the therapist, hey, how often did they do chores when they were growing up in their home? I was like, excuse me? I'm just curious. I don't know about chores, but I know that they grew up in a home where one parent was incarcerated. See where I'm going with this, you guys? I said, so when that client came into your office and you saw the report from the peer support, you saw that they're pushing back, your first thought was that they are resistant to following the rules and not trying to figure out, do they even understand what's going on? Their why? So I said, well, how about you go back? Go back and ask. If I recall, of course, I'm not going to recall specifically how the response was, but I'll never forget the strong relationship that this therapist built with this client. And the reason why I know it was because I was out at a community resource program. This person lived experience share about it. I was out, I think last year sometime, at one of the Goodwills, and this previous client came up to me, and actually like a leader working, and I knew they looked familiar, but being like a program manager, I didn't engage with clients on a clinical level. So when I remember a client, you all, I always remember, unfortunately, when I was a program manager, I remember the ones who always were in trouble. Something was going on. And so I remembered the face, but I couldn't quite remember who they were, but I knew, I said something about this one. So I reached out to that therapist because this former client said, hey, please reach out to Miss Megan. Man, she helped me. I love her. I know we're not supposed to love y'all. We got boundaries, but man, that woman did this, X, Y, Z, just everything. So when I called up the therapist, it was that client. She was like, oh my God, Shreeta. She said, you got to remember. And she started telling me all these things. And I was like, there it is. Helping people to learn how to switch gears, to be able to fit in this ethical place, to be able to fit in the insurance space, to be able to comply with what we have to in policy, as well as be the social justice revolutionaries, social workers who are about our people, and clinicians and peer support and therapists. We can still do that while being ethical and responsible. And look what happened. This individual superseded the expectations and was doing her own thing. Right? That collaboration is key. It wasn't never about resistance and ambivalence. It was about finding out where that client was. Engaging. Educating. Hey, I get it. This isn't your thing. And guess what? I could share an experience of mine where something wasn't my thing and how I navigated that. But let's remind you of the goal that you had. You want to do X, Y, Z, get your kids back and do this. And if you are open to it, these are some ways that you can do that and meet that goal you want. These are some of the things that you can accomplish if you want to. That client's no longer resistant or ambivalent now, huh? Harm reduction approaches understand that change happens on a spectrum. Yes, I get it. Stages of change. We know. Someone just may not be ready or even capable to stop doing one thing. But what they are capable of doing is taking steps to improve. You all know what the definition of recovery is and harm reduction. Any positive change. Any positive change. You know how the 12-step programs say keep it simple? Well, hell, in harm reduction, they keep it real simple. Any positive change is going to lead to me reducing the harm to myself and the circles around me. Any step towards a positive change that I can identify in my life. So yeah, you may not be ready to stop using at all, anything. But this person has the ability to take steps to reduce because there's something inside of them that they are expert on that will allow them. It's an uncomfortable conversation, y'all. It's uncomfortable as hell. Because at the end of the day, you did go to school. You did get the work done to become the expert in the field. The most humbling thing about my first year in this work was to learn that I was not the expert. To know that everybody under me is an expert. Oh, feels so good. And empowerment, we understand as professionals, it is our job and our duty to support this beautiful journey, this beautiful transformation, not dictate. Empowerment and the ability for people to change happens when they have options, not an ultimatum. Now, I'm going to tell you something about my DUI group. My group is from 6 to 7:30. I don't like systems. And this is a recorded webinar. I get 10 minutes. Class has to start at 6:10. It means that my door locks at 6:10. No ifs, ands, or buts. I found out that I have a 10-minute leeway before or after with this class. And when I found that out, because I'm going to follow the rules and policies of this organization I work with. And I said, it makes sense to do 10 minutes before because how dare a system say I have to lock a door at 6 o'clock? And I know I struggle sometimes with life getting on time, being on time, but I was on time for y'all today, by the way. but I struggle because I'm human. So after 610, I explained at the top of every class, you have choices. You may not have a choice in a system, but you have a choice in this class. This is my spill. Not kill, because that's terrible. I create the space of safety and bravery by starting with the engagement, education, and empowerment at the beginning, because I only have an hour and a half and I may not see this person again. And how I start that class is I close the door and lock it at 6:10. If you are unable to get here by 6:10, when this class starts at 6 o'clock, then unfortunately you will not be able to enter that day. I ask that once I have finished doing sign in, everyone mute or they lower their phone so I do not hear them. It is a distraction. However, if you are unable to turn your phone off because life is happening outside of this, meaning you got kids, you got family, things are happening that I do not know about, you may need to take a call, by all means. That's why it's on vibrate or silent. I expect for you not to fall asleep in the class. There's rules, you guys, from the system, how they want people to operate. They don't make rules on how I engage. No, you are unable to sleep in this class. Yes, I get it. We are tired. I work a full day and I show up here to do a 6 o'clock class. I'm just as exhausted. However, I expect for you to be present just as much as I am, because that's the respect, the mutual respect we have for each other. If you are unable to do that and you are struggling, you are welcome to stand up and pace. You are welcome to step out into the air, because we have a door that enters goes right outside. You can get some air. However, I want you to be mindful. If you are gone more than just 3 to 4 minutes, I will have to exit you out of the class. It is not my responsibility to keep up with you. The last thing, we do not get out early. However, when you do a check-in and you answer the check-in question, you have participated. So if you are in the class today and you absolutely do not feel like conversing and engaging in the dialogue today, you have participated because you answered the check-in question. It takes me all of 6 or 7 minutes to get through that spiel. By sharing up front the expectations and allowing my participants to see just exactly how we'll operate consistently every once a week that I show up for this class, has built the trust, has built the relationship through the engagement process, has allowed them to learn, to understand the consequences of their actions, which empowers them to make the best choice for themselves. And have people been locked out of the class? Absolutely. Have people been discharged from the class because they've missed three times? Absolutely. But what I find is that the reason why Shreeta doesn't have complaints is because they're aware. Application question for core principle 3. How can we shift? How can we shift from prescribing the solutions to co-creating a plan with our clients? Is leading us into this. How can we shift from prescribing solutions to co-creating a plan with our clients? What I share with you is an example of how I'm able to follow policy while at the same time meeting the harm reduction responsibility, which is meeting the person where they're at. Listen, I did a group for moms. These were case managers who worked with women who were abusing and using substances while pregnant and parenting. It was difficult engaging the beginning because I got it. It was scary. However, there is an opportunity for us to be reminded that we do have an ethical obligation on how to respond. And so that presentation of what I do for a DUI class is part of that. As we move into harm reduction and ethical practices, I want to actually begin the conversation with the case study. Let me look for my other notes. Professional codes, and you guys, if you are clinicians, you have requirements. We have requirements to take an ethics class every 3 years right now, I believe. You could, do a thumbs up or something if I'm saying it right. But every practitioner is a social worker. Thank you. I remembered. As a social worker, medical providers, we all have ethical codes. I'm not going to go through listening to ethical codes because you're going to get it from those trainings. The ones that I like to emphasize is the respecting of autonomy, doing good, beneficence, avoiding harm, and justice and equity and care. In harm reduction, those specific areas, which should be a foundation for every medical and clinical person working with another individual. Respect, doing good, avoiding harm, justice and equity and care. It aligns directly with the ethical responsibilities as a harm reductionist. Why? Because it prioritizes the individual. It prioritizes the person who's sitting in front of you. It is about reducing harm instead of punishing behavior. For clinical people, because that is my wheelhouse, it's about understanding the relationship a person has towards a substance instead of penalizing them for doing the only thing they know how to do at this moment. And ensuring that if I'm going to provide solutions, as I build this relationship and provide the support, that the care is accessible to everyone, underserved and unserved. Let's look at our case study. Now, kind of tired of hearing my own voice. So my moderator, and one of you all jump in and read the beautiful case study for us.
Alex is a 27-year-old who has been using opioids for several years. He has had multiple relapses and is hesitant to engage in treatment due to past negative experiences with providers. He is currently self-medicates with fentanyl, but is interested in learning about safer use options.
Sit with that, you guys. Sit with that. Here's your client sitting in front of you, whatever role you play in their life, using for several years. And honestly, this is probably right out of the book of some of you all's notes. Multiple relapses. Not really engaged, and actually sounds like what Stephanie said earlier. Continuing to use. Some people are like, I'm not even supposed to be talking to them because we're not supposed to even engage clinical practice when people are years on. La, 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 la. Ooh. So how do we do this? So traditional approach means this person is non-compliant, treatment failure. Oh my God. Now, what I like about this group that's on here is you guys are really like, I don't even like that word. I don't like non-compliance. I saw that from someone. I'm like, that's so cool, right? So you guys are really like on top of it. And it, again, it really warms my heart to see this. But let's talk about practical. What can we do? What can we do with Alex? The practical implementation. Let me go back. Sorry, I moved too fast. My notes are actually on this page. So for engage, how can we build trust with Alex and create a non-judgmental space? If one person could answer that and someone can read out their answer, because there's 3 questions I have. The first one is on engage. How can we build trust with Alex and create a non-judgmental space?
By understanding his feelings and why he's using.
Good. Yeah, so it sounds like that person is saying asking questions.
Be honest, open, actively listen to him, and acknowledge his past poor experiences with workers.
Mm-hmm. Yep. I love it.
Ask
Anything?
Alan what he needs from me
Yes.
to feel safe.
I like that question. What do you need from me? Because if someone is continuing to use, guess what, you guys? Ethical responsibility to share what your role is in this relationship that you guys are in. Because now you can actually put it back in Alex's place, right? In the engagement process to say, Alex may decide, you know what, I'm going to take my chances. I'm leaving you. This engagement process is building trust. Hey, you know what? I hear you. Thank you. I'm going to ask, how can I support you? And yes, if they say, I want to see you every week, it is now your responsibility, right, to share what your role is and what your capacity is supposed to be in this relationship. That's the engagement process. So I see something in here. Someone says, identify why it is important for him to find safer options. Yep, I know. That's me. I'm ready to jump into educate. I'm like, wait a minute, you got to do this safely. You're going to keep using anyway. I get it. That's a great way to meet. But remember, we got to back up for a second. The first thing is our ethical responsibility. Now, we can create this story, but look at it from your role. Say you work in a program like mine, DUI, mandated. That answer is valid. Hey, safer use is what's needed. But what are we missing in the engagement process with jumping to that? I haven't shared with Alex as he's going to be self-determined and make his own decision. I haven't even discussed why he's here. I don't know why he's here and what his next move he wants to do. And I haven't discussed my role. Right? I love it. Some people are saying, can we talk about what initially got him into his use? Yeah, we can do that. We can start there after we find out why he's there, what he wants. He may not want to talk about that yet. It is a slow process. That's literally, it's not a microwave, y'all. It's an oven. And we cooking a turkey on 200. So yeah, so that pause right there is the first. Let's find out that sitting with you, because sitting with a clinician who is an abstinence-based approach may not be the best space for him to be if this is his route. And as well as making sure he's informed about what it looks like leaving out of that office that day. It is the engagement process of him knowing what I'm getting to know you, you're getting to know me. Right? It is really getting to establish the whys here. And as you establish the whys, once you, yes, Keep it real simple. Why are you here today? When that answer comes out, it could be anything. I'm here because my PO told me I had to show up. I'm here because my family is mad at me. I'm here because I really want to figure out how to do this, but I'm not ready to stop. I love that, Morgan. Simplicity means a lot to clients. We're just trying to figure things out. I want to keep using. So say he says, I want to keep using a little bit. I'm not ready to stop. If your role, who you are today, right now, is in a residential treatment, is in this, you have to decide ethically, can I continue to operate with this client? And is it justice and is it meeting my client where they at by being open and honest with them about what that looks like? Or do I just go along with it and say he's just being resistant, he don't want to do this right now? So let's play with that. I want to keep using. I just came in here because, you know what, my PO told me I had to go. But I still want to, I don't want to stop yet. I don't even know why I want to stop or if I should stop. My response as a clinician. Okay, thank you. First, I want to acknowledge how difficult that may have been to admit that to someone like me that you don't know. And based on just a little history that was taken from a conversation you had. I can't imagine what you're feeling right now. And if you are open to kind of sharing with me, what is it that we could do right now in this moment? I would like to hear it. I don't want to just read off the paper. That's the way I operate. And this is real, y'all. This is how I talk to people. And if that's not okay today, that's fine too. Well, it's not fine because I have a PO and I could get locked up. That may be true. That may actually be true. If that's something you know, if you've had that written down, they've explained that to you. I want you to understand that I do appreciate and value what you shared with me. When a client hears you talk like that and start that conversation off, first of all, they're not used to people talking like that. They're used to people saying, you need to stop. You better do what you said. That kind of catches them off guard. When I move into, are you okay with staying for the rest of this session today? So now I'm asking them, because I need to know if this is going to be a push and pull session. Let's go with the fact that Alex might say yes. Let's stay. I'm going to stay because I have to. Okay. I would like to share that in this relationship with me for this treatment program, my role with you is to do X, Y, Z. This is how I am if I'm in a residential treatment program. For those that are coming to this program, we monitor their use and ensure that they decrease their use to abstinence by doing urine drug screens. What we are looking for is a decrease, meaning that that person stops. To stay in this program and to continue to go through our program and our treatment efforts, these are some of the expectations that are required here. Now, I can discuss, if you are open, this is the second one, educate. I'm gonna pause there because the question is, what harm reduction strategies and resources can we provide to Alex? Now here, I have to ask for some permission. Are you interested in other resources? Someone may have said that in the chat. How can we best use our time? I like it, Christy. What do you want to do? Yes, I love it, y'all. Thank you. Tell him some of the things that is happening with drug use and tell him you would like for him to stay safe. So this is where we move into it. Say Alex is like, I'm interested. I say, cool. So let me share the information. Great. LaTanya did it. We're getting close to time. So I'm going to kind of speed this part up. Y'all know I'm passionate. So here we are. LaTanya, if you look in the chat, LaTanya shared it, giving them all the resources because you asked and he said, yes, I would like to hear them. Cool. Here's the resources. In what I do is I remove myself a lot in my language, you guys. When I tell people like what's out there, I always use language like safety is first, safety for yourself. I remove myself intentionally because I don't want a client to ever center me in their decisions. And if you've done this work as long as I have, I'm moving into 18 years of working in social services. If you've done this work as long as I have, you know that a lot of our clients do things because they want to appease us. So I'm very intentional about my language. The first thing that we're going to talk about is safety. What does safety look like to you? How have you practiced safety with fentanyl? Do you know what's going on with it? Like those questions, I saw people saying, educate, find out what they know. A lot of our people that are using, they know what's going on. Ask them, what do you know about what's happening with the drug supply right now? You share with me because that'll help direct the conversation. That person may be saying, you know, I've been going to harm reduction SSPs and my PO got involved. Yes, what have you tried already? And that'll help you decide the resources. Now, here's the tricky part, because clients get happy. They get happy when you tell them you have all the self-determination and power to make your decision. Ooh, the third one, empowerment. How do we support Alex in defining his own goals and making informed choices? Oh, wait, you guys. Now, actually, this is the fun part for me. I use whiteboards. I like to help my clients actually see it, my participants actually see it. So it looks like you have a decision to make today. If you decide to remain in this program, I want you to tell me what you think the outcomes would look like. If you decide to move on from this program and explore these other routes for your pathway to recovery. What do you think the outcomes? And I always start with the person thinking of their own. What do you think your outcomes will look like? What that does for a person is it allows them to see, and it allows the clinician, the case manager, any role to understand how much information in the education, because education empowerment can be fluid, right? Oh goodness, they don't really understand. So now my role as a guide and support system is to share some of the potential risk. Harm reduction is about reducing the risk of harm, some of the potential risks. So yes, you are a part as a support person to share because you are an expert in and of itself. But you're going to find out where they're at because you've asked them. After you all have done that part, that empowerment, how do we support? You'll know based on their response to seeing that list. Now, we call it the pros and cons list. In clinical spaces, we've called it that. It's old, but really, we're just helping them have a visual and helping them identify, which someone said, what their internal motivation is. We're helping them also take accountability. I love that someone identified accountability can be triggering at times. You didn't say that word, you didn't say triggering, but we have a negative response a lot from people because it's been used as an attack a lot of times in a negative space. The cool thing I like to do in my classes is bring those words back around because I've allowed them to see. So if we take this route, either route, there are going to be either positive impacting consequences and or negative impacting consequences. And actually, in both routes, there will be potential negative impacts. For instance, one that I like to bring up to my participants and clients is the loss of friends that they built through a lifestyle that they're trying to transition out of. Wow. We got to start talking about the negative impacts. And that's one that usually is the example to help them set the standard. And it also opens the door for the client to be seen. Why? Because in traditional practices, what do we say? You got to remember the people, places, and things. You don't never think about how hard that is to let go. So when you use that as your initial and that engaging part, it allows the client to go, okay, I feel safe. And you guys have answered the questions in here. That empowerment is going to be a natural, and you as a clinician are going to feel so different. If you look at what you would have initially said in the traditional practice, the client is resistant, ambivalent, and is not even at pre-contemplation. But now, I bet some of you all will come up with, superb a clinical framework and how you will frame this client's journey. It actually sounds really interesting. Oh, it might be some knocks on the road. Yep, this client might get incarcerated. But guess what that client running back to? Coming back to you. Because you supported them. Oh, my goodness. As you can see, this is deep. But what I do love about this webinar is that you all will be getting a copy of what we've discussed today. Yay. Because we are really getting close to the end, and we didn't even take our next 5-minute break. So I hope you guys are not upset with me about this. But I want to just show you some things and share some things before we get to the end. And I do apologize, but I really wanted to make sure that we got a chance to dive through. When we talk about harmful language, right, and using non-stigmatizing, how do we engage? So we did talk a little bit on ways to engage, but let's talk about some of the harmful and versus supportive. I want to acknowledge in the field of substance use disorder, I love a big one, which is removing addiction as as an identifier, right? If you pay attention to language, you hear a lot of us in the field saying that we no longer, addict. You're an addict. You identify yourself, and it's heavily stigmatizing language. And I would challenge you all to think and share in the chat other harmful versus supportive. That was just one to give you the idea. There's substance use disorder. People are like, I'm good. You can keep talking. Okay. That's up to them on this platform. Reframing our language is big. What I've learned in being in the field, like I've learned that I've honestly been in harm reduction for the majority of my career, but intentionally practicing it now is it's not even as much as the language, but it's harmful for me to assume. And someone said that. Yeah, so thank you. Dirty, positive, relapse. Look at y'all, freaking fire. Oh my goodness. Yes, this is why I love to talk. When we don't check our assumptions, my way of working with people is not just stopping at what your pronouns are, is going, how have you identified yourself in your recovery journey? Because there are some people who are on this recovery pathway who still consider themselves to be addicts, and that's okay. I don't dictate a person's recovery and what it looks like. Well, you're not really in recovery because you still smoke weed. Is that me making that determination? Is that my bias? Or is this something they believe? Have I asked them? Have I discussed with them their relationship to substances? As you all can see in the chat, I could go down and I chose not to have a whole list of harmful and then supportive because again, this presentation would be much longer. But we can't, right, Diana?
Yes, ma'am.
Educate, co-creating the client, co-creating with the client. Co-creating the client goals, we talked about that. From prescriptive to collaborative care. I know that we have requirements by insurance. I know that, but being able to word it and be person-centered and understanding that a person has a right to move through this journey the way that they choose, even if that means that they're going to end up in a they're going to end up in a negatively impacting situation. I want to get to this right here. Offering low barrier support options. The low barrier support options are out there for you to research as clinicians and as people in the field. You've named them in the chat. What this does is it's just that recap for you. Is to say, what are the basic things I need to do in these 3 areas? Engage, educate, and empower. The conclusion, I'm speeding through because it's 2:59. Well, it's 2:59 here where I'm at. The conclusion and the takeaways that I want you all to focus on and that you'll be able to get in this PowerPoint as you receive a copy yourself is that the best way to improve an effective treatment outcome, if I'm using treatment-focused language, is to establish and integrate these approaches within your practice. I want to engage and meet my clients where they're at, which may be uncomfortable for me, but if I'm truly being person-centered, it's going to achieve the highest outcome. While I'm engaging, my role is to be honest and truthful to my client with information they're going to need to empower them to make the best choice for themselves because they are the expert in their life. I am at the end of my time, and I don't have any space for open discussion according to this platform. I don't know if you have the ability, Diana, or anyone else. I do have about 20 minutes left. If there's time for people who had something that they wanted to share. I know we didn't get to the question. I'm sorry, you guys, but this is it's a lot, and we actually just scratched the surface.